Beta blockers in COPD. First, a definition.
Your heart pumps blood around your body through a network of blood vessels, known as the circulatory system. Your blood then supplies the cells in your body with the oxygen and nutrients they need. If your doctor has prescribed you beta blockers, such as atenolol or bisoprolol, it may be because you have an abnormal heart rhythm, or angina, or heart failure, or had a heart attack. Beta blockers work by blocking the actions of hormones called adrenaline and noradrenaline. These hormones make the heart beat faster and with more force. Blocking them makes your heart beat more slowly and with less force, which reduces your blood pressure and the strain on your heart. Before you stop or change any medication, even if you're worried about side effects, talk to your GP first, as changing or missing a dose could harm your health. For more information about beta blockers, visit bhf.org.uk/beta blockers.
Yeah. The cardiovascular disease, which is common in patients with chronic obstructive pulmonary disease, has a profound effect in morbidity and mortality. Yet, the condition is often unrecognized as the result is untreated. Applications in medicine. The beta blockers have positive effects on morbidity and mortality in patients with heart failure, in those who had a myocardial infarction. Most retrospective observational studies must suggest that such positive effects also occur in patients with COPD, have cardiovascular disease. And then we have another video.
Phonic cardiac rhythms or rhythms could be a risk factor or could be a side effect of some of these medications. And we talked about before that COPD is not a disease that is limited to the lungs. This patient has significant cardiovascular conditions. So how are we doing as a healthcare provider to treat their cardiac risks? Are we using beta blockers? Are we using those medications appropriately? Or we still, I have a lot of my colleagues that they have concerns about it.
There are a lot of people with concerns that I think are not so founded in the data. We know that the number one reason that patients with COPD, that most patients die with COPD, not of it, and many of them die of heart disease. We know that beta blockers, especially the cardioselective beta blockers, not the non-selective ones, but the cardioselective ones, are actually ones that can be used safely in patients with COPD. And if your patient has heart disease and they have COPD, then they really do need that cardioselective beta blocker.
Then we have the pros and cons, and we have another video.
Welcome to Insider Medicine in Depth. I'm Dr. Susan Sharma. Individuals with chronic obstructive pulmonary disease who take drugs used to treat a variety of heart conditions are less likely to have exacerbations of their lung disease and may even live longer, according to research published in the Archives of Internal Medicine. Here's some information about COPD. The term refers to several long-term diseases of the lungs, including emphysema and chronic bronchitis. It causes progressively worsening damage to the airways in the lungs related to swelling and blockage with mucus. It is usually caused by smoking or exposure to secondhand smoke. Researchers from University Medical Center Utrecht studied the medical records of over 20 general medical practices in the Netherlands to look at the effects of beta blockers on those with COPD. Beta blockers are used to treat a variety of heart problems. Cardiovascular disease and COPD frequently co-occur occur in the same individuals, so it is important to know how drugs that treat one condition might affect the other. The investigators identified over 2,000 individuals with COPD who were aged 45 and older. During an average follow-up period of just over 7 years, more than 47% of the participants experienced an exacerbation of their COPD, and about 30% died. Those taking beta blockers were less likely to experience an exacerbation of COPD and were even less likely to die during the follow-up period than those not taking these drugs. The benefits of beta blockers were unexpectedly found among individuals both with and without cardiovascular disease. Today's research suggests that contrary to current conventional wisdom, beta blockers may not be dangerous for those with chronic lung disease. In contrast, they may actually appear to benefit those with COPD. For Insider Medicine in Depth, I'm Dr. Susan Sharma.
In pros, we have along with their potential cardiac effects, beta blockers have non-cardiac targets with potential beneficial effects in patients with COPD, such as reducing the systematic inflammation, the number of globulate cells, and mucus release. Thus, the beta blockers may have beneficial effects in patients with COPD who do not have clear cardiac indications. Cons: the patient who received metoprolol there was a great risk of severe exacerbation leading to hospitalization, and very severe exacerbation leading to intubation and with mechanical ventilation. Although the FEP1 was similar in the two groups, there was a greater increase of the scores of breathlessness in the metoprolol group, such as which suggests an effect adverse of the drug in COPD symptoms. Then we have the issue applying Ecuador.
Hello, I'm Jack Dunner, a senior lecturer and physician in respiratory medicine at the University of Otago in Dunedin, New Zealand.
And I'm Leanne Parkin, a public health physician and epidemiologist at the University of Otago.
And I'm Josh Kwon, a final year medical student at the University of Otago.
Along with some other colleagues, we undertook a study to explore the use of beta blockers among people with COPD and comorbid coronary heart disease. So why was it important to do this work? Well, acute coronary syndrome and COPD are leading causes of health loss and death in New Zealand, and they're among the most frequent reasons for hospital admission.
In New Zealand, clinical guidelines recommend that all people should be on a beta blocker, a statin, and aspirin following myocardial infarction to prevent further coronary events and deaths. And internationally, COPD management guidelines state that patients with ischemic heart disease and COPD should be treated the same as people without COPD, and this includes prescribing beta blockers. Despite this, studies in several countries have found that people with COPD and comorbid heart disease are undertreated with beta blockers. However, it was not known what was happening in New Zealand.
We used the National Health and Pharmaceutical Dispensing data from the New Zealand Ministry of Health to follow a cohort of patients with COPD who started taking a long-acting bronchodilator between 2006 and 2013. We identified patients who had an ACS admission during follow-up and explored the use of cardiovascular prevention drugs in the 6 months following an ACS event. We found that only 57% of patients were dispensed a beta blocker, while 81% received a statin and 88% received aspirin. We also found that there were differences in beta blocker use by severity of COPD and also by some demographic characteristics, as you will see in our paper.
In conclusion, the use of beta blockers in this cohort of patients with COPD was much lower than expected based on findings of general audits of ACS management in New Zealand. Conversely, the proportions using aspirin and statins were similar to the proportions found in the general audit. This suggests there is a particular reluctance to prescribe beta blockers to patients with COPD, and more work is required to explore the reasons behind this apparent reluctance.
Last but not least, the conclusion. The result of this trial should not determine or deter the use of beta blockers in patients with COPD who have cardiovascular indications with catheter that the risk-benefit ratio should be considered carefully in patients with severe COPD in high risk of severe exacerbation. Thank you.